Hello, hello. Hey everybody. Thanks for coming. Thanks for making the time. I'm Dr. Shadia Rafage. A couple things to talk about. How many folks in here are veterinarians? Great. How many technicians? Great. Wow, it's like 50-50. And then how about other folks in the field? Vet students, anything like that? Cool. How many folks have sutured before? Okay. And how many have never done anything? Yeah.
Anything real now.
Okay.
Yeah.
Good. So the hopes is that we're going to start off very basic with this, and then we'll move up the chain of complexity as we go on. Any questions, let me know. Anytime. This is informal. There are going to be suture patterns that are fairly routine on here. There are others that I don't even use, but I want you to have exposure to them. And some folks here know how to perform those procedures better than I can. Feel free to help each other out. It'll be a collaborative effort. A little bit about me. I'm Dr. Shadia Rafage, boarded surgeon. I went to vet school at Cornell University and did my internship at Angel. Afterwards, I became board certified in small animal surgery. From there, I left New York, went to Las Vegas, practiced there for about 9 months. And after that, flew around the country doing surgery. And then I went to Silicon Valley, managed 3 hospitals there. I was on call 24/7 for all 3 locations. That was about a year. And True Care for Pets, I was part owner, transformed that hospital from an overnight facility to 24/7 ER multi-specialty. And then the end of 2019, I began VetTriage, which I own and chief medical officer for the past about 5 years now. So this is the outline. It's a long list of things we're going to do today. So hopefully folks will find this incredibly practical, clinical, usable information. PRN, thank you so much for sponsoring the talk. And please, if you haven't done so yet, visit their booth in the exhibit hall. And then also a thank you to Dr. Kirk Miller, who gave me all these videos. They're phenomenal. So these are his slides. I've modified them to fit my style, but thank you, Kirk, for the contribution. So I'll start off with some basic information here. Suture type. So typically for mucosa, subcutaneous tissue, or skin, you want the suture to last on the matter of days. Whereas you're talking about fascia, you're looking at probably weeks that the suture has to be intact. Tendons could be months. And that's in general the rules that we follow. Monofilament suture versus multifilament. So monofilament has less tissue drag. It harbors less bacteria, less likely to pull through. Pull through, for those who don't know, is when the suture, for whatever reason, it can be patient factors or surgeon factors, tears through the tissue you're trying to suture together. And that's called pull through. Multifilament has easier handling, better knot security, but it's got more material to it. It's multifilament, it's braided. So, yes?
Just a quick question.
Sure.
At least 2 of us here have no place to sit at the table and paid for the extra fees to be in this class.
Yeah, where is...
What do you mean? Just pull a chair over to the table.
Yeah.
What are you talking about?
We need the kits
Yeah, we
too.
have no kits either.
So you guys have needle holders and suture in front of you there. Let me see if we can, I'll have to get Kevin, he's operating this whole thing, let me find out. I thought he brought some extras. Thanks for letting me know, thank you.
Yeah, no,
There's plenty of room up here. Somebody said. I mean, I was just listening to how I was doing my back. I mean, there's a spot right here and just you bring a chair.
They're locked together, the chairs back here.
Oh, they were, they come apart.
Yeah. What was it, what the
there. Some are locked and some are not.
I don't mind sitting out there, 'cause I
Are you ready with the skylight or you're?
It's not that I don't mind sitting back here,
Does
it's
it
the
turn into
We'll
a
have it the first time.
Is that your handwriting or is that?
sitting there and
No.
practicing.
That's much nicer than
I have a new graduate that.
Okay, they're gonna be contacting PRN now to get this stuff up here.
Okay, thank you.
Yeah, no
But
problem.
he doesn't know how to read cursive.
Thanks, guys. Okay.
Yes, they do.
All right, so multifilament or braided material has more involved with the material, so therefore when the body's trying to break it down, there's gonna be potentially more inflammation associated with it. And of course, because of all the little crevices that the multifilament suture has, bacteria like to live in those areas, and so there's risk of harboring bacteria. So I don't really use multifilament at all. I'm only using monofilament. Does anybody here use multifilament suture? What do you use it for?
Occasionally use it like if I've got like a mass in maxilla or something, or between a toe where that rigidity of the monofilament is gonna cause some discomfort. I'll use a multifilament, kind of feels a little more flexible.
Well, nice, okay, yeah, yeah.
Or lots of people use Vicryl, that's, now Vicryl.
For dental?
Yeah, and dentals.
Yeah, Vicryl is a popular one, great.
Eyelid mass removal.
Eyelid mass removals, wonderful,
Use it there just because that way, in case there are any tails, they're not scratching.
wonderful, wonderful. Okay, cool, thank you, thank you. So the degradation profile is different for absorbable, which are meant to be temporary in the body, versus non-absorbable, which are meant to be permanent. And then in regards to suture size, you want the smallest adequate diameter, you want to decrease trauma while you're placing the suture, and you want to decrease foreign material. So the smaller the diameter, the better. However, you want to be realistic about it as well. You want to make sure that the suture is actually going to hold the tissue that you're suturing together. But in an ideal world, smaller is going to be better, and that's because you're going to be penetrating the tissue with the needle each time, and so you want to minimize holes like that. But also, you decrease foreign material by using a smaller diameter suture. Oh, thank you. Yeah, who was missing the sets?
Oh my goodness. We are short. Somebody snagged them.
Uh-oh,
I'm gonna
okay.
try to grab some for you. Give me
I can
time.
give you one.
I apologize, yeah.
Thank
How many?
you.
Okay, I'll be right back.
Thank you. So then just some examples for absorbable suture. These are, you can categorize them as short-term, medium-term, long-term for absorbable sutures. So short-term sutures, mucosal sutures that are used in the face or oral surgery, dermal sutures, especially in young animals, 6 to 7 days of wound support with complete absorption in 56 days. An example with PRN is Monomed ST, but there are plenty of others as well. And then when you look at the medium-term absorbable suture, you use these for general closure, for skin repair, subcuticular, soft tissues, including muscle, stomach, intestines, uterus, bladder, ligatures, for pedicles. 14 days of wound support with absorption in about 2 to 3 months. Another example here of a medium-term, mid-term absorbable suture, and then long-term for general closure, subcuticular, cardiovascular, various body parts there, and then wound support for 35 days, absorption in about 6 months or so. And another example of a long-term suture, absorbable suture. These are all the things you're thinking about when you're trying to decide what suture do you use, what part of the body, what's the goal, what's the patient, comorbidities involved. All that comes into play when you're trying to make a decision, and that comes, of course, with some of the literature, but really just a lot of practice. So this is going to be our first knot we're going to practice. Now, all the way I have these organized is first I go through this wordy and almost useless description, but just to kind of get your head thinking about it, and then we'll follow up with like a drawing and then an actual video of somebody doing it. So just bear with me, that'll be the way that we're going to go through it. Your kits, and for those who don't have them, when you get the kits, you have in front of you needle holders, some kind of thumb forceps, they have different ones sometimes, and then there's that rectangular fleshy thing with incisions in it. So we're going to practice on those. And then there's suture material in the center of the table, so you can open up those packs and grab suture. And then the cup in the middle is for your sharps. So for the needles, when you're done, please throw them in there and nobody get hurt. And then we'll jump straight away into this square knot. So while you guys are opening them up, I'll just go through some of the aspects of your kits. A couple of common, things that come up. So the suture is very smooth. It's got like no drag to it, which is great for the patient, but kind of annoying for artificial stuff. So just be aware that as you pull in the suture, it's going to slide really easily sometimes. Sometimes it'll get snagged like on the tablecloth or whatever. Just be aware of your surroundings. And the fleshy boards there are great, but again, it's not real skin. So there are going to be some aspects to our training that may not be realistic for the stuff you have in front of you. We'll make do. We'll get creative with it. So the square knot is the most frequently used knot. It's very secure, less likely to unravel, and it's not ideal for areas of tension. And for those who don't know, tension is when their skin edges are being pulled apart by any number of factors. Most often it's because the area you're trying to close does not have a lot of flexibility to it. And so your closure is very tight. And when you have a tight closure like that, the tissues are being stressed, and of course the patient is going to move. It's inevitable. And so it's going to be stressing your closure. So areas of tension, we have specific ways of handling this, which we'll go through, but tension is a very big deal when you're closing incisions. So a square knot consists of two simple throws, a second simple throw in the reverse direction of the first. Both throws must begin with the needle driver between both strands of suture. It'll become evident in the next slides. Key points, think of both sides of the suture as a circle. This is going to be a common trend when we go through all these suture closures. Stay in the circle. It'll make more sense as we go through it. If it helps, watch just the short end of the suture has to go side to side, start on one side, go to the other, back and forth. So this is what we're aiming for. When you place the suture, you're looking for this sort of pretzel shape. That's what you're aiming for. So you're going to take a bite on one side of the incision, come out the other, and then you're going to have this twist to it. And that's a square knot. And then this is just two square knots on top of each other. So the next one is going to be, this will be the video that will start. So if you folks I'll play the video several times, don't worry. And we'll do this for every single suture. We'll just keep playing the video while you guys practice it as well. So a couple of key points. First off, notice how Doc is holding the needle holders. So a thumb in one ring and then ring finger in the other. Some folks palm it, so they'll have a thumb in one ring, then the other ring is left empty and just held in the palm of your hand. But all of you, for the sake of learning, thumb, ring finger, and then notice he's going to be using the forceps for pretty much everything. Use it to grab the edge of the incision, use it to grab your needle. You try to minimize using your hands in surgery because your gloves are going to become contaminated by the patient's bacteria that are normally found in the skin, whereas the instruments have a lot less messiness to them when you're using them to manipulate the instruments and the instruments and the patient. Okay, so just notice that. Also notice where he is holding the needle. So if you see here, the needle holders are holding the needle not right in the center of where it curves, but between the middle of the needle and where the end is, the part that the suture is attached, somewhere in that region there. That's where you're going to be holding the needle. Okay, I'll let this play out. So take a bite on one side of the incision, come out to the other side. Now, in the circle. So inside. Yeah. And grab the other end and pull. And that's one square knot or one throw. And he's doing it again, and you can just keep repeating that process again and again and again. Beautiful. We'll do it again. and then feel free to start trying on your prosthetics. As we go through these, I'll help with more kind of finessing how to do all this stuff too. There's lots of things to learn from just something as simple as this. So feel free to try it out, and I'll walk around the room and see how these go. Yes, question?
How many throws do you consider as a secure knot? 4,
Yeah.
5, 6?
So the question is, how many throws? How many times do you do this when you're trying to close something? The answer is depends. Depends on the suture type that you're using, so which suture material, and depends on what you're trying to achieve. Most of the time, if you're using like PDS, 4 to 6 in that range. It just depends on those factors. There are definitely times where I don't mind if it's a bulky knot at the end of it, and there are other times where it's like I don't really want it that bulky. You know, if you're talking about like a perineal urethrostomy, for example, you don't want bulky knots there because the mucosa is already going to be irritated by the suture material that's there. But if I'm talking about like a joint surgery, you know, where it's going to be stressed because the patient is going to move that joint, then I'll go toward the 5 to 6 knot range. So it depends on what you're trying to do. Laryngeal paralysis is another example where I want a lot of security there, and I don't care that it's bulky. So I'll put a lot more knots there.
It's really hard to not do a surgeon's knot first.
Yes.
Out of sheer muscle memory.
The next one will be surgeon's knot, and we'll be using it a lot.
Really hard.
Choke your hand up with a good peg.
Can I ask you a question?
Yeah.
I don't know if it knows, but I had been taught years ago that you shouldn't push the needle
Mhm.
through the skin. You should put the skin onto the needle, and that you shouldn't go like this through
Yeah.
both
Yeah.
sides. That you should do one side,
Come out and then
come
to
out,
the
and
other.
then go through the other side. But he did in the video go
Yes.
through one. I know it's not real tissue, but is that still current?
Oh,
Or is that
absolutely, yes.
antiquated?
Yeah, and the only reason why I mention it, yeah, is because it's already a lot of information for the folks, so I'm going to mention it later on. But yeah,
I
yeah,
just wanted to make sure,
absolutely.
because that's, and I never
Absolutely.
use my fingers to grab the needle, and
Yep.
he did that too.
Yep, yeah.
So just, but
Yeah, you want
I
to.
graduated in the 90s, so things change.
Oh,
I
yeah.
just wanted to make sure.
Yeah, no, that's still the way to do it. That's still the way to do it. And in fact, even when you saw him grabbing the edge of the incision, you're right. I just like push down on it to try and, like I push down on it with the forceps closed, and then that everts the tissue, and then I have the edge, and then I can grab it. Yeah, absolutely.
And then also too, like, you know, if you're trying to get really close to the edge, you know, you can invert it and get like.
Right.
Yep.
Yep. No, you got it. Those rules still to be applied. When you see those rules being broken, you know, folks just got a little lazy and.
When I first graduated, I was working at this.
How we doing? Easy peasy or?
Don't want to grab the tip of the dull. Partway down, don't grab it.
But they were teaching
Or at least have it partway
layer
through.
for the body wall that was not. They did that.
I'll replay the video for those who want it.
You want to try and touch the needle all the way to have a little bit there. What you do is carry the long end of one needle. Around your
I'm like trying to like figure out anything to teach myself now.
Just so it lays
If that's,
nice
I
and
don't know
flat,
if that's
wraps around.
realistic or not, but.
And you don't want to pull it too tight. You don't, that's too tight. That's perfect.
Years before I learned that I'm supposed to write on.
Second throw. Good.
Yeah.
And then
Years.
third throw.
They say that the solvent can go through the faucet and get
At
into
this point, you give yourself, see how you still have some room there? So the nurse doesn't yell at you when you go to take them out, okay?
They really
Then you
do.
just put some
Yeah,
water.
so they say you gotta put it on, you know, on a sticker. I was like, I learned that about 10 years out. It was probably probably 2005 when I was in. I've literally done that 800 times.
Yeah, my practice manager was really.
How we doing, folks?
We could share as a sincerely pocket.
Okay. Okay.
I do apologize.
Yeah, folks, for those who are missing, the kits, we'll have to share. I think it's just that table.
You know what we could do? We could cut one in half.
Hi?
I'm gonna lift that one edge. You wanna do this is too much.
Is that all right?
Yeah, whatever you guys. Thank you. Okay. Okay. Thank you very much. No, that's fine. Thank you. All right, folks, we're gonna move on to the surgeon's knot. So the surgeon's knot is pretty much what I use for everything. This is a very common knot. Surgeon's knot is also known as a friction knot. It's for high tension tissues that cannot be properly opposed using a square knot. The surgeon's knot differs from the square knot due to an extra pass through the loop of the first throw, double overhand knot followed by a single overhand knot. This extra twist in the first throw provides more friction to maintain its position until the second throw is placed. Again, it'll make more sense once I show you here. This is the drawing. So you'll recognize this, that's your square knot, but this time the first knot we're going to place is a surgeon's knot, or a surgeon's throw. So you're going to do 2 passes through, not just the one like you did with the square, and then you'll follow that up with square knot. So if you're using this in a real patient, you're going to go surgeon's knot and then a bunch of square knots. That's how these work. And then the video, and then you folks can try it when you're ready. So notice again how he's holding the thumb force, the needle holders. See where he's holding the needle, and he's pushing the suture, the needle through, just like before. And then you're going to form that circle, going inside the circle. But now you're doing it twice. See that? And then grab the other side and pull through. And then he's going to follow it up with a square knot. That's one throw, right? It's a square knot. Boom. And then you can do whatever number of square knots you want. Typically 4 to 6, just depends on. And I'll replay it again for folks who need it, and we'll see how things are going. Play it again.
Here, then you're going to grab it. You're going to bring it back through again, okay?
Where you're hitting the light or whatever.
The more you practice this, the more.
How are we doing? It's so annoying. It's so annoying. I know. I mean, the ideal is to have a cadaver. You know, that's the best thing to do. I don't know what kind of needles. I don't know if these are taper or cutting.
All of them, paper and cutting, but no reverse cutting.
Okay. Yeah. Well, we had reverse cutting yesterday.
Oh, you have a reverse cutting? I thought so.
Yeah, cutting. Yeah, cutting's probably the better way to go if we don't have reverse cutting. I can't imagine taper is working well.
I'm using.
Have you tried it? You are?
Okay. I just have
Okay.
to push a little harder.
Okay.
I work with rabbits, so it's nothing.
Oh, that's.
Yeah.
How you folks doing?
Yeah, they're like.
Yeah.
Reverse cutting over anything.
Are we getting it? How you doing? Okay. Do you need help? Are you still working at it?
Oh, and that's.
Yeah, do it. Let me know.
Okay.
We'll play the video if you need that.
Take a breath and look at it.
How you doing? Yeah. So usually it's my non-dominant hand is holding the end of it, and most people will wrap it around their hand. Oh, so the needle for me, like if I'm manipulating all this stuff, right? So I'm like, just manipulate it like that. So I do my bite, right? Then I come through, and I'm gonna pull it out, and then I'm gonna do like transfer this, and another bite. And so theoretically, you're always like transferring the needle. Now that being said, in real life, we're always holding the damn thing, but we really shouldn't be. So most of the time, you're just transferring the needle from one instrument to the other, and you shouldn't be hopefully holding it at all. So if we do this in intraoperative.
Yeah, I actually.
Just like that.
So instead of once.
Okay, gotcha.
This, you have to do.
It's all good. There's being stuck under the. Yeah, and it should be. I see what you're saying now. It should be like on the sterile field. It should be like hanging off the table. That will happen, and then have to just redo it, throw away the suture, and get a new one. But.
I was thinking you were putting it somewhere else because mine's always.
Notice, every time.
Yeah, no problem.
That's sort of how you check, that's what I know
How you guys doing? Okay. Thank you for helping each other and dealing with the shortage. We had the snag stuff yesterday, I think.
That's lucky, yeah. I'll get there eventually, but I know it's good because I'm still on even if I
So always short.
Okay. It's nice looking out right there. So, yeah.
yeah.
You're right, that's why they're getting ready to do a second time.
Yeah, a lot of times, you know, some people do a sheet, which is just halfway through.
Yeah.
There you go. That's right. There you go. There you go.
I would say, get that in there. You need more exposure than you need.
And that's where most of the time you cut there, but like, say that way.
So,
Like this.
looks like you started not here, but it has this coming out.
Exactly. Like this is a space.
There you go. Open the jaws. Oh, yep, there you go. So do we just going up a little bit. There you go. And then you have to, and then so, yep. And then pull, or you can go the other side. Yeah.
Now, this is one, you're wasting structure, and two.
It's practice, for sure.
Getting that knot.
You can grab it. If I,
Right?
let's go in a cat body.
And pull it
Well,
through.
you'll find it, that really, another nurse has to purchase the whole thing.
Oh, then you cut it. You cut it by accident. That happens too. Some surgeons hate needle holders that have the scissors right. I love it. Yeah. Right.
I want a pair of just red sharp scissors, you can wear those, but most of the girls don't.
Yeah. No, I love the scissors with it.
Yes.
Yeah, I know. It's all right, folks. We'll go to the next one here. So this will be our first suture pattern. We did 2 different suture knots. This is now going to be a pattern, simple interrupted. This maintains tissue position and strength if one portion fails. It has minimal holding power against stress. It requires more time and more suture. So, unbeknownst to you folks, you've already been doing simple interrupteds. You just haven't done the sutures in a row. So if you see, these are what you've already done, but you're just doing a bunch in a row with the goal of closing the incision. And so this video will show that. So he's taking a bite from one end to the other, and then he'll do a surgeon's throw. So 1, 2. Am I in the wrong video? Let me see here. Sorry. No, this should be it. Okay. Oh, he did a square knot. Another square knot. Square knot. Another square knot. Cuts it. Okay, then I guess it doesn't show it. And then you just do another one next to it. That's what you guys are doing. Just a bunch of these in a row. And the idea is to close the incision. So feel free. Yeah, some of you have already done it. Obviously, you've been practicing it, but that's simple interrupted for you. We can move on to the next one if folks have it, or do you want to? Okay, we'll move on. So these are cool. Oh, let me grab my laser pointer. Cruciates are fantastic. So we're moving now up the chain of complexity. Again, for some of you, this might be still very basic. For a lot of you, it might still be, it's going to be more practice. So a cruciate, 2 simple interrupted sutures placed parallel to each other and tied across the incision, forming an X. It's an appositional pattern. So real quick, appositional pattern means you're opposing the 2 edges of the wound, right? There's also eversion and inversion as well. Eversion, the 2 edges of the wounds pop out like that, they pucker up. Inversion, the 2 edges sink down. And there are indications for when you want to evert or you want to invert. But most of the time, you're going to want appositional. Just right on, flat, head to head. The cruciate pattern is good for low to moderate tension. It's phenomenal for that. The security is similar to simple interrupted sutures, but it's going to be faster. You are going to use more suture material. And this is a drawing of what you are aiming to achieve here. So so far, you've gone across the incision, and then you tied a surgeon's throw or a square knot, thank you, square knot, and then you're done. For this one, you're going to take a bite, but then instead of doing that knot, you're going to come back around to where you started, next to the first bite, take another bite, and then you're going to do your surgeon's throw and square knot. And that's, you're going to form that X shape. The video will explain it, and then we'll practice. This is really great if you have like a patient that's critical, you're trying to get them off of the operating room table quickly. Cruciate, although it takes up more suture material, it's much faster because you can incorporate a larger span of incision with each suture that you place, with each knot that you place. So you see he took a bite from one end to the other, and then he's just starting over right next to it. Nothing special happened, he's just starting over right next to it. There you go. You see what he's got there? So that's what you're looking to get, something that's shaped like this. And then, surgeon's throw, and close. And you've got an X. And then followed up with a square knot.
Okay.
Also use this for really long incisions like radical mastectomies. It helps with that. Let's say you're doing a cystotomy and you place the stay suture in the bladder and now you want to close that hole. Cruciate is good for that as well. I also use it for lymph node biopsies in the abdomen. It helps with that as well. It's fast and it just pulls tissue right together. Especially if you have bleeding, like a lymph node, you can suture right together with one, like mesenteric lymph node, one cruciate will take care of it. Or if you do punch biopsies, this is great for dermal punch biopsies. I'll play it one more time, then I'll come around the room and see how you guys are doing. All right, let's see how we're doing. Okay. Whatever helps you out. For sure. Yeah.
And then in body wall, like.
Mhm. Yes. Yeah. Yeah, I'm okay with it.
Okay.
You mean like linear, you mean? Like,
Yeah.
yeah, I'm totally okay with it.
Okay.
Mm-hmm.
I'm still too new to feel comfortable
Yes.
continuous, but that takes.
Yeah, for that type of tough tissue, I'm totally fine with it. I wouldn't use cruciate for like an enterotomy or resection anastomosis. Not for any reason other than I don't know anybody who does. But for body wall, I think it's great. I think it's great. Yeah. Yeah.
If you leave too much, then you gotta worry.
How we doing?
Good. Enough material.
Those are masters like this, huh?
It's tight, yeah, but you're gonna pull it tight first before you go to the next one. So, you know, this is where you wanna hold your hands, that's. Yeah, good.
Yeah.
What you can try to do if you want, instead of going to both sides of the incision, you can go like this instead if you want. You can go like this. Like you take your bite and come out like that instead.
Skin swells, doesn't cut into the skin.
And then go back in. The other side. See? Instead of going straight through, if you're struggling with that, then you can do it piecemeal. You wanna try that? See how that goes for you.
Comes out, and it's not where you want. Grab it.
Oh, okay.
It doesn't work very well.
Exactly. Well, you want it,
Grab it with this, once it's gone through, pull it through, grab it.
Yeah, you don't need that.
Okay.
You're just gonna use your hand.
Oh, yeah, but not. Yeah, if you want to, you can just cut it out and use get another pack suture if you want. It's okay.
So just.
Up to you.
Once it comes through,
Yeah, the knots are annoying.
yeah, so you like pull it through, and it's like, this is all wonky, right? So you go to.
Go in there and then just
It
grab
works
it.
a lot better with the brown acids and the aptitude.
There you go. See?
How'd that work for you?
You're just picking it up.
Better? Okay. Nice. Pull all the way through.
My biggest thing I do that's bad is I use my medicine bombs instead of switching to mayos for cutting like that.
There you go. Nice. Perfect.
There you go.
Just use a mayo.
So it's.
Good looking. Now in a real patient where there's like blood and stuff like that, that'll actually hold more. Right now it's kind of loosey-goosey because of the material, but nice job. Anybody want more time with cruciates?
Dana had it.
Yeah, take your time. I would play the video for those who want to watch it.
That's where you do want a little bit of slack, not too much.
The more you throw these, the more you get used to doing it.
So do it the way you work.
First one.
There you go.
Oh, you guys use VetTriage?
Yeah.
That's right in.
I don't, you know, you do it so many times, you don't even think about which way to go.
I have a question, I don't think you're gonna go over this, but I just wanted to ask you about it, cause I never really understood the method. Forward interlock.
Oh, we're gonna go through that.
You are gonna do it, oh, cause like, what's the point of it, I never really understood, all they have to do is write one thing and it comes out.
So
It's not really that fast.
So one of the benefits is that if you do break one part of it, it's actually less likely that it's going to unravel, unlike simple continuous. Again, I don't use it. It's a large animal surgery thing, you know, but swine animal vets do use it, but I don't use it. So there is some
So the
security
idea
in
is that
that.
it won't completely,
Yeah,
only maybe
yeah.
one or two will come out.
And I think it's supposed to be pretty fast too.
Really?
I
Maybe
think
it's
so.
because I'm not that great at it.
Me too, yeah. You still? Yeah, same.
Yeah, for animal like this simple continuous, I think they look ugly, so
Yeah.
for interlocking looks prettier for me.
I always get cruciate in the skin, cause it's also tension relieving.
Yes, I like cruciate for the skin too.
And I don't even do that now because my skin particular, usually my edges.
Take care of it?
I do it when I get like it's not even.
Yeah.
So that I can go, higher on the
Yep.
low side and lower on
You
the high
can
side.
adjust it as you-
And make it look beautiful.
100%, that's exactly right. Yeah.
It is beautiful.
All right, folks, we'll go to the next one here. So we're gonna move up in complexity. We have the horizontal mattress. Horizontal mattress pattern, and again, bear with me with the text. I know it's gonna be not straightforward until you see it. The horizontal mattress pattern starts by creating a simple interrupted pattern, but instead of tying the suture, the needle is inserted laterally on the same side as the needle exited. It crosses to the other side of the incision and exits directly across, lateral to the first site of entry into the skin. The suture ends, which should both be on the same side of the incision, are then knotted. This is a good suture pattern for areas of tension. I use it a lot for joints. It's useful in the skin, but may cause eversion if not applied correctly. And eversion, like we said, is that puckering up of the wound edges. This could cause blood supply issues as well, but you can prevent this by using stents like buttons or tubings. I've never used buttons or tubings before, but this is a concern, so that's why I use it for really tough tissue. I wouldn't use this pattern for more delicate tissues because of that reason. But let's go through the picture here. This is what you're looking to achieve with it. So if you notice, you take a bite on one side of the incision, come out, and then while you're on the same side of the incision, take another bite and go across, and then you tie it. And you can see that the knot this time will be on the side, not over the incision, but on the side of it. And what you're also going to notice is when you do this pattern, this skin edge is going to be pulled into this one, and that's what creates that tension. It's a very strong suture pattern. I'll show you on the video, and then you folks can practice it. So horizontal mattress. Take a bite on one side, like you've been doing, come out the other side. Then you turn the needle around, and he's going the opposite direction next to his first site. See that? So you have like a U shape. And then surgeon's throw. Notice he's pulling parallel to the incision, and then square knots. Parallel to the incision. The tension is parallel to the incision when you're closing that knot. We'll play it again, see how you guys do with it. But that's the horizontal mattress. Okay, replaying.
No, so, it is really pretty much exactly cruciate. It's just the way that you pass the needle. That's all that it is.
What was that?
So, cruciate, as a, this was, you start with. It just feels so nice. So, yeah.
I'll replay it one more time and then I'll walk around the room and see if I can help.
Cruciate that you did, okay? Your next step is here, and you pass that down again. This time, person. Heel, okay?
Anybody need any help? Look at that. Yeah. See, it pulled that incision real tight. It's good. You can barely see it. Yeah.
So you did that in reverse, and instead of being like.
How's it going?
X, we now have
Oh,
this,
yeah.
where it is saying.
Nice. You're doing great.
Like, what kind of wound is this supposed to be?
You gotta find a way to grab that side, right? So maybe we do the loop. Let's see. Start over again. Let's see what happened.
First, the pattern is, and that's.
Leave, that's perfect. Leave that alone. Yep. Yep. Should go quick. You don't want to lose your. Just a little bit longer. You don't want to lose it.
So basically you can do.
There you go. Okay.
Cruciate.
So now you can do a surgeon's throw.
In the market.
Yep. Yep. One more. There you go. Perfect.
Oh, when you're doing that backwards.
Keep going. You're almost there. Keep going.
Yeah.
No, you want to grab this side now.
There you go.
Yes. Yes.
Switch.
Now you're gonna pull it parallel to the incision. Yep. There you go. There you go.
I've heard of it, I think I've seen it once.
There you go.
And
And then do a surgeon's throw.
Right there, perfect.
The other way. This one.
So like, hold it,
There you go.
like, yeah, so you do this, pull it back like that.
Yeah, those forceps are killing us, huh?
No,
No, I do a forceps for
like
this.
flip it back out again. It's like, I think they put it down or something, flip it back out and then
Nice.
cut, and then we flip it back in to grab it or whatever. I'm not even totally sure. I'm not
Yeah.
even totally sure how to do it.
Nah, I mean, when you're starting, like you're still placing more throws? Oh, okay, so it depends on what you're doing. So if it's gonna be something where you think that the suture knot is gonna be kind of bulky, so you're closing like this, like a cat and the skin's very thin, you want short tags. Or the PU surgery, I'm doing a very short tag on the mucosa side, a long tag on the other side. So it depends on what your goal is. If I'm doing like a TICA, for example, where I know it's gonna be a gross healing, it's gonna be annoying to remove the stitches, long tags so the staff can grab the stitches and manipulate it and whatever else. So it depends. In the abdominal cavity, the fear with long tags is adhesions. So you want long enough that you don't think it's gonna unravel, but also short enough where you're not getting adhesions. You have no way of knowing that, but that's the theoretical. Doing okay?
Actually, want two, remember, to sort of.
So like here, watch my, so instead of pulling kind of like that, you wanna make sure that you're pulling both.
Yeah.
And you want that not.
Usually it's either because you've tightened it really tight, or it's because where you've taken your bites, are not like symmetric, they're not even, you know? So if you're slightly off, it's going to shift everything, yeah. And then the other thing that you keep in mind too is the depth. So you want to, and this might be hard if you're doing it blind. Yes, yeah, yeah. So this pattern, again, will only really be used for like skin and maybe like joint capsule, you know, from my own experience with it. These are areas that are going to be like, it's going to be kind of blind when you're cutting it, but you want it, or closing it, but you want to be able to gauge how deep you're going and keep that depth the same each time you take a bite. And that'll prevent the aversion from happening. Yeah, so I'll use this if like I already repaired and then revised an incision, or like a big dog, like his skin, and it still fucking fails. Then I'm like, all right, I'm gonna go and risking blood supply disruption, but I gotta do something. It keeps dehissing, you know, and so I'll use it for that. So for me, it's kind of more like a salvage procedure. I have used it for certain patella luxations because it'll pull the patella into the groove a bit, but for that I usually use vertical mattress, which we'll do next. But, play the video again for those who want to see it. You guys doing okay? Plenty of experience here. Yeah, that's right. Yeah, and you can tell because it's like pulling this up, you know, pulling this side towards that end. Yeah. So I would use it for either like those really long incisions on big dogs that already failed on me like once or twice, and they keep dehissing. So then I'll use this, even though it risks the damaging the blood supply. You know, if we've had enough, it's annoying. It's time to do something like this. Or I'll use it for like joint capsule, especially if I'm doing like a patella luxation. It helps pull the patella into the groove more, and it'll hopefully withstand the dog's range of motion with the stifle. So that's usually when I use it. Otherwise, I'm using really the next pattern that will do vertical mattress, maybe way more for those circumstances. But that's where I'd use that. Does anybody here use horizontal mattress, like routinely? What do you use it for? What part of the body? What purpose?
Whenever I see tension in my skin incisions, but for mass removals or things like that, there's tension, I tend to go to this one.
Yeah.
I think I have the tension relieving, this is the one that stuck the best.
And the good point here is keep in mind you can combine different sutures, right? Because as the incision is going over the body, there might be an area of the incision that has high tension that you use this for, but then the rest of the incision you can use simple interrupteds or cruciates. Yes. 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 So fortunately, knock on wood, I haven't had it be a problem yet with microvascular disruption. I imagine that if you are placing a lot of these really close together, then it's a bigger risk, but I haven't seen it be a problem yet. Yeah. Yeah. And that's why I only use it for like those cases that are giving me trouble, that's already failed once or twice, and I've had enough, then I'll use this one. But that's only my own paranoia too. But yeah, some folks use it pretty routinely in areas of high tension. But I think putting multiple in a row is the risk, I think. So maybe putting like a couple just for an area of tension, the rest of the incision using simple interruptants or cruciates, there's enough collateral circulation to hopefully take care of any trauma that you may have caused.
I would want to be able to get
All right, folks, we're going to go to the next mattress pattern. Vertical mattress. So the vertical mattress pattern involves entering the needle from the incision line on one side and exiting on the other side of the incision at the same distance. The needle is then turned and entered from the incision line and exited from the incision on the opposite side. Suture ends are tied. This is another tension suture pattern. It's stronger than horizontal, less tendency of eversion, could still cause blood supply issues, but I do favor this one over horizontal myself. And this is what you're aiming to do here. So they took a bite, right, from one side to the other like you normally do. However, now they're taking a bite on the same side in front of where they exited, and then coming out in front of where you entered. And then you're tying the knot, and the knot will be on the side. So we'll show you that in the video. You're gonna want to take wider bites for this one. So really like come out here, take your bite, and come out really far, because when you enter back, you're going to be in front of where you entered and exited. I'll show you now in the video. All right. So see how he's going far back on this incision, or on the incision. And then, now this is a good time to talk about this problem. You see how he's like struggling to get the needle across the incision? So what I recommend almost always is, instead of doing it that way, it's okay to put the needle through and come out the incision with your needle, and then go back in, and then go out the rest of the way. So you can practice that as you do more of these, but you can going all the way through like that. It's cooler, it's faster, it's lazier, but you have to make sure that you're not bending the needle. The needle could break. It also could be annoying when you're trying to struggle through it. So keep that in mind. We're gonna replay the video for the mattress pattern, but I just want to bring it up now.
How is that not like far, near, or near, is.
Yeah, those might be the old names for them, maybe? I'm not sure. 'Cause I've heard of that before, but I thought folks use that for like subcuticulars and stuff. But maybe not.
Is it?
For the
Then what's
yeah.
What's this one? This is what I
Yeah.
thought was a vertical mattress. And what's that one? So the horizontal?
This one here?
Yeah.
What, are these two together?
Yeah. Because I thought this was a horizontal and that was a vertical, and that was in far, near.
I think that is an alternate name for it.
But it looks totally different.
I have to see how you did that one. I'm not sure.
Okay.
These look like horizontals.
Yes, and I thought this
Yeah.
was, this is what I called a vertical mattress,
Oh,
but I could be totally wrong.
No, yeah, because you have to enter in the same plane as where you entered and exited. Here,
Okay.
here, yeah. It has to be. That's why it looks weird. Yeah.
Yeah. So I wonder what this one is.
I don't know what that one.
I don't use it, so it doesn't really matter.
Yeah. No, here, like if you see when he takes the bite, where he re-enters the needle. So he comes through like normal.
I break 5.
It does make it easier to remember how to do it though, if you call it a far, near.
Yeah, that literally describes what you're doing.
Now I wanna know what the heck this thing is.
All right, and then he's gonna turn the needle around, and he's gonna enter in the same plane. See, he's gonna be in front of it now, in front,
But I had to do a full.
and then he's gonna exit in front of where he entered originally.
I like my.
I tried that, but then
Because
it's still.
Boom.
I think it's just the shape of the needle.
Near, far, right? I think that's the other one.
That's what, oh, they do have. I saw you reach for the.
Can I show you this one?
Yes, yes. Let
I'm
me-
curious now, if it's not, since it's not vertical mattress, I wonder what the heck it is.
Yeah, let me replay the video and then I'll come over. Excuse me. All right, let's replay it. Hey.
So understanding that, I always thought that was horizontal mattress, and then
Mhm,
vertical, which I said is the wrong name.
Well, right off the bat, you're supposed to be going across the incision for a vertical.
Well, right, that's what I'm saying, it's not a vertical.
Okay.
Apparently, clearly I have the name wrong, so this is what this is.
Oh, you had, right.
So it's this way,
No,
this
no,
way,
no,
this
no,
is
I have, one surgeon.
Yeah, I don't know what that one is.
Just hand me the card.
Yeah.
But it's not tension relief, so that's why I think it's.
Yeah. But you've seen that one, you've seen that done before or written up
I
somewhere?
don't know, where did I get it from?
Yeah, that I don't know.
I always thought that was a vertical mattress, but, so but I don't ever use it, so it
I
doesn't
actually-
matter.
Yeah.
so-
It looks like a mattress type pattern, but I don't know what that is. Sorry.
It's okay.
Simple continuous.
Yeah.
Throw a suture really-
The other name, okay, okay. Maybe for next lab, I'll enter that kind of
Break
stuff.
down, you're going-
Well, I remember being taught that, but then when I went to my residency, no one ever described it that way anymore. They replaced it with this.
Partway down, that way.
When I did like spay neuter clinics as a student, we learned that.
Yep.
Doing okay? Flying good? Easy peasy. We'll get more complex. Oh my God. I actually put those down as like the bonus ones because we had time. Yesterday we had time to do it and people were like, what is going on? So it's good, yeah.
I learned hands-on, so I figured it would.
Yes.
Yeah.
We'll have that. That one's towards the end, like consider more the complex.
It's like, you know, there are other suture materials out there.
That's,
You can use
so
those.
what he said, that's what I'm hearing too.
Yeah. It'll be, yeah, I didn't learn it either. I learned it from this course. And
I
I'm,
was just saying, one of my favorite techniques that I learned was with the continuous.
Yeah.
Just to throw, like when you're doing a full like chain mastectomy in a cat, throw a knot in the middle of it.
Yeah.
Over there so that you have, you know, if one end gives out,
You
have
can still salvage it.
You can still salvage.
Mhm.
I thought that was great.
Same thing with the cystoscopy.
Yes, no, exactly.
Yep, 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 yep.
The continuous.
Or even just throw one or two
Yeah.
simple interrupters in after you're done.
Yeah.
They say for cats that you're supposed to tack down your every third one anyway.
Yeah, you want, cause you wanna put at least 4 knots in. And then you kind of, there you go.
I'll replay the video one more time and then we'll move on. So we'll play the video again.
My son who's off to the,
This is one of those. These knots, one of my used to do. On one project.
It doesn't matter.
Yeah.
And quite frankly, if you wanted to do a space vision that's this big,
Yeah, let's play one you do know, we get this.
So just closing is the key with the
No, and it's faster, you don't have to do a circuit, so instead of doing a circuit, you
Well,
circulate
yeah, well, you
every
you wanna have a bigger
row.
bite,
It's
it looks like.
your
I'm guessing that's what the issue is.
You want to be.
Cause cause that's a risk for suture pull through. Yep, yep, yep. Yeah, the smaller ones, cause that's the microvascular that microvasculature you're worried about hurting, yep. Yeah, I think a bigger bite.
And she was coming from the Y, and that was coming up from the top.
All right,
Cat spay, get
everybody ready to move on or need a little more time? Okay, guys, another suture pattern. So simple continuous, starts with a square knot, one diagonal pass, one perpendicular pass. If the needle advances above and below the skin, that's called a running suture, it's not as good. This is minimal tension holding, good apposition, good seal. A problem for breaks, because if one portion of this continuous pattern breaks, the whole thing will probably fail. This will start off at one end of your incision the same way you've been doing it, basically as like a simple interrupted. So you'll do a surgeon's throw, a bunch of square knots. However, you won't cut the thread. You'll instead take another bite next to it, go across, go back around, cross, back around, cross, and then you'll close at the end with a knot. That's a simple continuous pattern, and we'll go through the video now. So after that first knot, the rest of it is like as if you're starting over and just never finishing your knot. So you take a bite, come through. You've already done this now 1,000 times. No, maybe 100 times. Surgeon's throw. Square knot. Another square knot. square knot. He's gonna cut that tag just a little short, just because. Better for the patient. But now he leaves that other end intact. Puts the needle back in the needle holder. And he's gonna come through. A few millimeters is the distance we're looking for. 2, 3, 4 millimeters. It just depends on the patient and what you're trying to achieve. See, so all he did was just take another bite. And if you notice, he started on this side, right, to start the first knot. So when he starts the continuous pattern, he's starting on that same side to come across, and then the same side to come across. This is a simple continuous pattern. Now, if you notice, I'll reverse this or rewind this a little bit here. At the very end, when he's ready to end this, so if you notice, what you're going to have is a loop. Let me reverse it again. Here. So you're ready to close it now. Okay, I'm done with my incision. How do I end this thing? You have a loop there. So instead of pulling it tight like you've been doing, you have a loop, and then surgeon's throw, grab the loop, tighten. So the only difference now is that you have a loop with your surgeon's throw square knot, whereas before you'd have just 2 strands. So don't let the loops scare you. It just pretend like it's a strand. Then a bunch of square knots, like normal. And now when you're cutting it, you're going to have 3 tags instead of 2, which is what you're used to. So there's no real difference there, but the loop sometimes will freak people out. It'll be a surprise. So we'll start again. And then I'll come around and see how you folks are doing.
You need to go one more bite and just give yourself a little, like, feel along with your hands. And it can be hard to get things. That's your.
Now what you may want to do is make sure it's nice and tight, because these can be kind of a little bit loose.
Yeah.
So you want to hold them.
I was told not to put it too tight, because then when this.
Yeah, you have to use your judgment how tight you want. So for example, like the cruciate pattern, sometimes I'll do the same thing where leave it a little bit loose, I know there's going to be swelling there. So use your judgment, but just want to make sure that the tension is maintained to some degree. Exactly, because I'll do enterotomies with this pattern, so I need to be tight, But for skin, yeah, it can be a little more loose, especially if you expect swelling to be there. Oh, yeah, in the middle is what I'm going to do with the jaws open, and then this part you can tighten both sides. Yes. So Yep. So I start with in the middle, the jaw is open, because sometimes that'll even it out. And I also want to minimize like pulling on the sutures, I might break it. If I still feel like getting more tension, then I pull on either side, both sides. Nope, no, not in my opinion, no. Oh, I thought you meant for the quote. No, I think her question pertains to tightening the knot. Yeah, that's why I do that. Doing okay? All these lives are being saved. Good job.
And doesn't matter the order?
That part of it, when we're trying to make it tight, right? What you can do is unlock these, hold the jaws open, and then pull. There you go, yep. Because what that'll do is it'll even out the two ends of the suture. The two ends, it'll even out these two strands. And then what you can do after that is you can grab each strand separately with the needle holders and pull them to tighten it. So exit there you go. Now grab one strand and pull on that by grabbing. Yeah, and then pull that to get it even tighter. And then you can do the same thing with the other strand.
Oh, yeah, it's hers.
There you go. Pull that. It helps you get a tighter knot at the end.
Might be
I mean, come on. Is there even an incision there? Look at that.
Yeah.
Looks good. You okay? Yeah. All right. I'll play the video one more time for folks who want to see it.
Yes. You're like, how many are in there?
Totally makes sense now that you say that, yeah.
I'm actually going to.
Yeah, I went through that too, my friend that said it's like exercise.
I see it now, then I won't be able to unsee it now.
Her name is Olive.
Alright, that's cool. It's like so obvious now that you mentioned Olive.
I was like, it must be some human thing.
It's the same thing.
She brought her here, so I went to see her, she was in her vomit. 15 socks came out.
Just.
It looks like a circus car, we're like, she was like, well, what's that? And there were like 3 socks. And she was like, I want every one of my daughters and her. Some dogs are so wonderful. I know. I was like, I don't know if that's child abuse. I wish we had another one, because it was unbelievable.
Because there's less skin that way.
So now that you've got your, got this nice and short. Now, all you're gonna do is for like 2 weeks. Not throws, no, passes.
So you're always the suture.
That's the direction, so that's what you're talking about, that, where it goes across rather than up and down.
Sometimes when you're on the thigh, because the joints are flat, so you actually have to. like right here. It's either tail or the butt. So it can be hard to.
Okay, so-
So
Okay. There you go. All right, now pass it.
Oh, so you're good there.
so that you remember where the butt is, so that you can input it.
Isn't that great? That is great.
And
That
it's
makes
just
sense.
doing that with the 10 years old, it's all like,
Well, no, you're just,
all these years I was blaming it on the doctor.
All right, so that's your simple continuous. And let's go to the next one. Forward interlocking. So how many folks here use forward interlocking? Couple people, yeah. Yeah,
yeah,
yeah.
not since vet school.
Okay. So.
That's almost last century.
The forward interlocking is a very common large animal closure, but some small animal vets use it as well. I don't use it, so this one we'll go through together. Modification of a simple continuous pattern. Each passage through the tissue is partially locked, linked to the previous passage through a created loop of material. At the end of the needle is reversed, knot is tied to the loop left in the suture material, allows for good apposition, good stability if it breaks, more suture materials used, and more difficult to remove. However, in yesterday's class, someone said that they work with somebody who can just cut one side and unravel it. But okay, all right.
And so we're getting neurology, and our surgeon used that to close it.
Yeah. So that's what you're looking for, and then we'll go through a video. So you can see how through passage of the suture, through one loop and the other, you're creating this locking mechanism here. So when you're, instead of a simple continuous where you're not going to be inside the circle, right? This one you're going to be inside the circle. So here's your circle, and now when you take your bite, you're going to be inside it. I'll show you a video. Forward interlocking.
Okay, yes, so you want this a little bit bigger. Okay, and now, there's your knot, you're gonna loop around. and
This
make
was
your-
Abomisms,
Okay.
remember those?
Or exotic specialists.
Yeah.
So it takes a bite like normal, like you've been doing, surgeon's throw, all routine, right? Easy peasy at this point. Square knot, looking good, straightforward, no big deal. All right, perfect. He cuts only the one side, just a little short, trims it. And then now to start the forward interlocking. Here he goes. So again, on the same side that you started, he started on this side. So when you come around to this part, you're on the same side. Now when you take your bite, you're going in the circle. See that? It's in the circle.
So trapped.
Yep, trap it in there. Whereas before the simple continuous, you were outside the circle. So
There you
again,
go, perfect.
perfect. I love it. So again, here's your circle. You're forming that circle, right? Where normally you'd be outside of it. For this pattern, you're going to be inside the circle. And you should feel it lock in.
Oh, no, it's, yeah.
No, it seemed like for the simple interrupted, he was purposely going at like a 45-degree angle, and here he's going at like a 90-degree angle. Does that make a difference with the forward interlocking? Like when he pulled it, they were slanted. You know, they weren't going straight across on the simple
I think that was just a variation that he's doing. I think in all cases you want to be perpendicular to the incision. Is that what you mean? Like you 45.
Like when he was doing it, and he had his incision, when it was done and he pulled it, it looked like this. Whereas this one is going.
Oh. Yeah.
It wasn't.
Yes.
It was at
That's
like
right.
45-degree
Because these are getting locked in that position, whereas this one, because of the tension, it's going to do that. Yes.
Yeah.
That's right. Yeah. That's why for some incisions where I think there's going to be swelling, I like cruciates, because when I do this way, you can see the skin kind of pouching
Yeah.
in between. I hate that look. I think it looks like it's uncomfortable. So I'll use cruciates for that situation instead of a simple continuous pattern. Yep. That's exactly. Yeah. You're right. But the bites should be perpendicular to
It's
the,
just the way the material's pulling, cause
Yes,
it's giving the
yes.
shortest path.
whereas this one is, it's locking them, so
Right.
it's stuck that way, yep, yep.
Underneath there, shooting.
Yep.
Literally.
And then you can see when he ends it, similar to simple continuous, you're gonna have a loop at the end, and then you suture it the same, or close it up the same way. Surgeon's throw, pretend like it's just a strand, it's gonna be a loop, but pretend like it's a strand, so it doesn't freak you out, and then you can tighten both sides, and then square knot, square knot, square knot. So I'll restart the video again, then come around and see how you guys are doing.
Forward interlock is- Yeah, perfect, that's correct, right. And it does tangle.
You're gonna finish just like
And
this.
suture is almost exact, and that'll have a lot of-
Literally.
This is where I grab them.
Yes, that one, yes, and one is the centimeter piece. Sure, if you wanna have like 8 or 10 hernias.
Okay, so starting again here, taking a bite on one side, going across, just like you start every one of these closures. Surgeon's throw.
Do you have a preference if you're right-handed or left-handed? Does it matter if you start on the right side or the left, like the cranial versus the caudal side?
Yeah, so the question is if you're right-handed or left-handed, does it matter where you start on the patient, cranial or caudal? No, it doesn't. It depends on your comfort level. As a right-handed surgeon, I'm usually gonna go from right to left when I close the any incision, you know? There are also times where I've stood on the other side of the table to work the other direction. Just depends on what's necessary, but no, it doesn't really matter. It doesn't matter. As long as you're comfortable. The idea with a question like that, the idea is to minimize surgeon fatigue. Because if you're gonna be in the OR for a while or multiple surgeries, you want to do everything you can to make sure you're in a relaxed state. So if you're struggling because of the direction, then just switch. Go the other side, you know? Yeah. Sometimes we get so focused on the surgery, we forget to like question, like, okay, how's my body posture, you know? Why am I all like screwed up, you know?
Sometimes your neck.
Yeah, you have to be aware of that stuff. So if you find like your neck's hurting, for example, maybe it's where you hold your tension, or maybe you're just too tall and you have to spread your legs a bit so you can be lower. And now you don't have to lower your neck down. I have tall surgeon friends, and they're always bending their neck down like this. And I'm like, no, just spread your legs, yeah. And now you're shorter and you can just go without doing that. So.
I brought them in, my friends all fall off. Yeah.
Okay, and then to end it, so he's gonna. He's going to end it by taking a bite on the same side that he started, coming across.
But that's what the person was telling me when they said, do the left or the other, talking about on this.
Oh, not yet. There we go. There we go. There we go. There we go. So you want to end up on the same side that you started, so he reverses the needle and comes down the other side. And then he's going to close it. There you go. And then surgeon's throw. So some of you folks were asking about the tightening of the suture on the loop side. If you notice when he's closing this, the jaws are open to the needle holders. What that does is it allows for the tension on either strand of the loop to tighten symmetrically. So see how the jaws are open.
Jaws are open. What do you mean by that? The jaws are open.
If you're closing the incision with the loop, and you have the jaws open, if this is the bottom jaw, and this is the suture will even out.
As opposed to clamping it?
As opposed to clamping it. If you clamp it, you don't allow for the tension to shift.
Okay.
The alternative is to grab each strand of the loop and pull that independently,
Okay.
which usually I do both. I do a combination, open jaw and pull each strand. Yeah, if you get to that, if you get to the loop, then we can go through it. Yeah. All right, let me replay the video, and then we'll see how folks are doing. How's it going? Yeah, she's gotta take bigger bites. Yeah, being too delicate with her. And the bigger bites will help you see like where you need to choose things. Maybe work on this incision if there's more room, or this one. Yeah. Good. How's round 2, Doc? Doing okay?
The first one, you don't put too much tension.
Oh, you brought your nice. Oh, that's very sweet of you. So using brown accent thumb forceps then? Yeah, that's what I'm gonna recommend for the future labs, because these other ones are just terrible. We need brown. Oh, it looks better. Yeah. Yep. Agreed. I agree. Yeah. Yeah, we'll modify it for future labs then.
See, I wish I knew that. 10 years ago. I know, 177. Made it worse than coming to my I went to a spay lecture. I'm like, I don't know how to do a spay. That was where I learned about how to like it. This was a while ago. That was like a new thing back then.
I use the surgical tube
Nice and even.
and horizontal
Yeah.
and I'll put them in.
Mine's not even.
Of course, recently, now, 80% of the incision line is gorgeous. There's one area that I was like, I look at my surgical, go grab the leg. They put an extra well, which is so weird. Yeah, no, this dog had no choice. The whole thing I mean, to catch it early, great. But I feel like that's similar to oh, okay, you know what you're missing? No, it's fine.
Cats or dogs.
So, before you pull it,
Put their body in here and do the side.
this is interlocking.
And it holds some, but they said you can also just use sandbags. So that's what they did in Spain.
Instead of just your
So that technically.
and then see how the interlocking, they just make your pads interlock. It's just.
Well,
Anybody
for
that
anybody,
has trouble
but
getting to
usually
the-
you're only having trouble doing that.
Yeah.
But for anybody, it makes it easier to get done.
There's no efficacy reason that it's one's better than the other, at least I. I'm not sure.
All right, folks. So at this point, we'll take a 10-minute break. Folks can go do whatever you want to do. 10 minutes. We'll try and reconvene back here. Let's say at 4:25. If that sounds good. I know a lot of these have been basic for some of you folks. It's going to get more complex after the break, and also appreciate how far along you've come from when you first started. So good job. Thanks again for PRN for sponsoring this. We'll see you guys in about 10 minutes. We'll come back at 4:25.
I think that's just what these ones do.
Oh, great. I know, I was on C-section, and I remember your incision was great, and I'm looking at it going,
That's fair. I mean, I asked this myself.
YouTube video, that had a big scar, and one right now, we have, towel clamps. Yeah, right. Trying to get in and suture. When I saw it, I was like, oh, there's a lot of they're supposed to start. They're opening.
Where is Rowan? Rowan, yeah, it's in Jersey.
Okay.
Yeah.
Push it
Yeah, we the
against the
first in
body
Jersey.
wall. And that marks it.
Yeah, and you guys wasn't doing you Penn State or you, I'm not remember.
Yeah,
Penn or.
yup, Penn, yeah, or anything, yeah, Cornell, yeah, that's the only thing that's closed, yeah, and I'm trying to stick with it, 'cause I'm trying to plan a wedding, get married, things like that, and that's the only school as of right now.
And you just go up one side, down the other.
Really nice.
Uh-huh.
You wanted to say?
In your body.
Yeah, no, I'm trying to get in though, yeah, I applied already, yeah.
Ribs, and you're supposed to cut the ribs till you see white.
Yeah.
So they have 3 surgery tables and then a wet table and they all have anesthesia.
Blood vessels on the ribs.
And I was giving you a tour and there's a driver seat, passenger seat, and there's little tables for an RV for like people. And I looked at him and I'm like, you bring the taxi for you? And he's like, no. And I'm like, who's running your anesthesia? Yeah, because what I was told, we were like, oh, that's like back away. And I work with, first year. Entry, right? And so they're fresh out of school and they don't get them anywhere.
So the interns were like, and then you can then go back down, I usually tie off.
Because they get dangerous.
And then you take off the towel clamp, so if you don't have the towel clamp, you can have somebody hold it. But of course, if your assistant is holding it, then you're not adjusting the anesthesia, or whatever, so you kinda need like another person. But that towel clamp thing is.
Maybe just even more not baby doctors. No, every time I have to put the, put everything up, I have to grab my text, I'm like, hey, I put these all in the right places, can somebody double check me, because I don't do this anymore.
You're like, yeah, it does, like so much higher than it used to be. But I'm sure you've done construction and stuff, it's not really much, but it can be a little.
I was just, preparing because I'm actually moving to Pittsburgh in January from Ohio.
And then
So I'm like, what are the state requirements? I think it's 30. You're not paying for your own
Yeah,
right
I was running the problems.
God bless.
I would like it to be what,
I know for Ohio, like interactive.
Although I will say,
So it can't be.
I
Not
clear
on whether or not.
because they're
And so like, there were several things
big
that
dog
that
got a whole
were
lot
like,
of fast,
but I was
and
not.
a lot of folks real been locked down on it.
Which is why I took it. But I have more than enough credit. But there's a small percentage that's allowed to be wrong.
Oh, yeah.
Yeah, and it's not clear, and I did not get my, there was some talk in the practice about someone reaching out and asking if I
Oh, absolutely.
Right.
Yeah.
They just say suture.
But I mean, the other thing is you're gonna be doing other things too.
Generally, I'm like,
The further away.
No, but I mean, listen, I've been out for 23 years, I still check,
yeah, it varies from
you
state
know,
to
it
state.
just,
Pennsylvania, reciprocity from Ohio, I had to have Ohio board send a letter to them, saying that my license is in good standing. I had to have two veterinarians in there,
I,
just basically
but
saying, yes.
until you do a master model, you literally, I had my senior technician going because we had a massive tumor, this is the second off of the jugular, and I'm like separating the fascial plane, breaking it off, and he said, he's like, you debunk most of it, just, I'm like, you got this, just go nice and slow.
History check and your like
That was
FBI, your FBI criminal history check and like regular.
Well, they didn't have that option,
Ohio
so it was
So I'd have
a
to do
very
that.
long conversation,
I only had to do the
and
FBI version.
at the time, I didn't realize it extended so far down. But yeah, no, I sent one the other day, and the referral surgeon called me, he's like, gee, thanks for that case. It was another mast cell tumor, it was undifferentiated, he couldn't find the edges of it, and it had dehisced already, and I was like, we worked it up, we did everything, the ultrasound, we did this, we even put fluid in the abdomen, cytology, we did everything. And I just was like, man, if I just put a flap on this, I'm not sure I'm gonna feel comfortable doing it. Yeah. I'll do simple ones. If it's not a large flap, I'm okay with it. It's once you start getting into like the elbow, and you gotta get the, I didn't wanna mess with it. Man, when he called me, I felt bad for the dog. I was so happy I sent that one.
Cuyahoga Valley National Park, if you're visiting down there.
My one piece, I'm gonna give you my one piece of advice. Prepare them for the fact that you may have to amputate. The tail, because well, no, but this is something you need to mentally be prepared for, is the fact that that tumor, in order to successfully remove it, you may end up having to make that incision tight, and it can happen. I mean, I know plenty of people that too, and you just need to make sure that, hey, listen, get in there, it's really invasive, and I'm not gonna be able to close it with good vascular, because you have almost no vascular, you have very, very limited vascular supply. So prepare them for that. So if the worst case scenario happens, you've already covered it.
So I've always been but I love surgery. And all
Well, that's
all of ours are.
Yeah, but you know, people totally get their like favorite thing, you know?
You can come in just at each, just go through a couple, all of your little sutures.
Yep.
They're all
You're covering your bases, and 9 out of 10 times you're fine. You know, every once in a while, like, I've had a few years, that I'm just like looking at it, ulcerated tongue casting. I'm like, there's no way I can take this off and still have it successful close. And I'm like,
Why are you in this
this is what it's gonna be.
I mean, really to be able to call.
Hard finding jobs.
Exactly, that's true.
You can find that I'd rather like not get margins and then, you know, have to manage expectations.
Yeah, I mean, so, most of my.
I have an 8-month-old son at home, and I said, yeah, I had to get him.
We'll do ours for
I love it.
Let him play with it.
They're corgi?
It's a corgi.
Yeah.
Brown has them.
That's
Yes.
cute. Yeah. Like no
Yeah, so that's the other thing, like, cause they have
All right, folks, we can start again here. Thanks again to PRN for sponsoring this. All right, so I used to spend more time on tacking and walking sutures. These models are not great for them. So I think some folks here want to see the more complex ones anyway. So I'm going to go through them with you just so you're exposed to them. And if you want to practice it throughout, you can. But we won't spend too much time on these because these models are not great for it. Tacking sutures is when you tack the subcutaneous tissue layer to the deep fascial plane. It's great for eliminating or decreasing dead space. And it's going to be a little hard to watch on this type of video, but what you'll notice, and we'll replay it a few times, is this is for subcutaneous tissue. And the idea there is to tack the subcutaneous tissue down to the deeper layer. So he went from deep to superficial, exited out, went back in superficial to deep, and then now this is the tacking part. He's taking an additional segment of tissue, like in the meat of it, if you will, and then he's doing a surgeon's throw and all that. So we'll replay it. When I say superficial and deep, superficial is external, closest to you. The deep layer is the farther layer to you. So in this scenario, the deep layer is that dark pink, and the superficial is where the skin and the dark pink meet. Let's replay it. And again, I just want this for exposure purposes. If you guys want to practice it, you can, but we're going to go quickly through these two to focus on other more complex suture patterns and suture knots.
Is there any, if you're tacking to the body walls there, are you trying to get the linea, or are you just trying to get
Linea.
the muscle? Okay.
Yeah. I mean, it depends on obviously where you're working in the body, right? But if this, like for example, this might be like a spay, you're tacking it down to the linea. And I would not advocate tacking down in sequential order. I wouldn't do the whole thing. I would do it intermittently. I would tack it down. Yeah. I don't think it's most comfortable for the patients when it's tacked down, but if you're worried about dead space, it's worth it to avoid another operation later on. So that's tacking suture. I'll play it one more time, and then we'll move on to walking sutures. So deep to superficial. Superficial to deep. And then take a segment of the deeper tissue. There you go. And then close it off. So if anybody wants to review that, we can do it once we start practicing the next one. I'm happy to go through it with you. It's just hard to do it on these models because these incisions are not very wide. Okay. So walking sutures are a similar idea. The idea behind walking sutures, again, we won't do these on these models because it's not great for it, but you're welcome to practice it if you want to. Walking sutures are intended to take a wound edge and bring it closer to the opposing edge. And you do that through, this is one example, one way of doing that. So the bite goes into the subcuticular tissue, so the tissue underneath the skin, or the subcutaneous tissue, but usually you want strong tissue. So subcuticular tissue, exit out, and then when you take the next bite in the deep tissue, this bite is in front of your previous bite. See, it's not in the same plane. It's not over here. It's over here. And then when you tie it together, it's going to bring this edge over. And you'll end up with this type of pattern. And that's a walking suture. So similar to tacking sutures to some degree in terms of taking a deeper bite, but has a different point to it. It is closing dead space, but it's also helping advance the tissue over to make it where there's less tension in your final incision.
Can I ask for that one?
Yes.
Are you supposed to, like, let's say some huge mass on the side of the body wall, you've undermined like crazy, and you have all this dead space because you had to undermine it to get it to close. So you're supposed to like pull on the skin and take your bite and like pull it, or do you just let it lay naturally and take that bite and make it go? Do you know what I'm saying?
You take your thumb forceps and you can evert this tissue, exposing the deeper, the subcuticular tissue, and then from there you take your bite and then the bite somewhere cranial to it. Now how much tension you put on this, it depends. It depends what part of the body you're using. Because also, you can imagine if you took this bite really far in advance, you're putting a lot of tension now on the tissue, and you're also at risk for breaking the suture. So you have to use your own critical thinking when you talk about this type of closure, because you're going to modify. It's not going to be the same every single time. You're going to modify it throughout the incision. Yeah, but that's exactly where I use these. I use this for really large masses, like a huge like lateral thoracic mass or something like that. It's great for those types of. And usually I'm using large size suture because these are usually bigger animals, and so I'm using like 0 PDS for these. But if anybody wants to try them, feel free, and I'm happy to help. So these were actually requested by previous classes to learn inverting patterns. So we mentioned before appositional patterns, we mentioned before eversion, and this is inverting, where you're going to try and tuck in the edges of the incision. There are two types of inverting patterns, the Connell and the Cushing, and we'll go through the differences. This is primarily used for hollow organs, meaning stomach and urinary bladder most often. We're not really going to use inverting patterns on small intestine, at least on small animal, because you risk decreasing the luminal diameter. But for really expansile organs like urinary bladder and stomach, uterus, you'll use inverting pattern. It helps create a more tight seal. So the way this works is you're taking a bite parallel to the incision, and then going across, another bite parallel to the incision, go across, another parallel, go across, parallel, and the only difference between, and they're both the same, you're doing the same thing on both sides, the difference is this is more superficial, see where that needle is, versus this one's going full thickness. So this is a partial thickness, and this is full thickness. Because some organs, like the urinary bladder or stomach, you don't really want to enter the lumen. It may cause problems. But for uterus, it may not matter as much. So for times where it matters, you go partial thickness, full thickness for when that doesn't matter. But either way, they're both inverting. You do it the same way. So you start off with your surgeon's throw and then go parallel to the incision. I don't think I have a video for this one, so this will have to go based on the drawing. Question?
Is that basically just like a continuous horizontal mattress?
Yes.
Yeah.
That's exactly right. Exactly right, yeah. And I think that the pattern you were doing before, it reminds me of this to some degree, right? Yeah.
Except there's only one.
You did only one, yeah.
Instead of continuous.
Yes. This is a continuous pattern, right. So if folks want to practice this one, go for it. I don't know how many of you actually use it, but it's nice to see what it does to the tissue when you do it. And I'll walk around to help since there's no video for this one.
Yeah, that's what I was told. It just cuts it off.
Remember, you're starting off the same way you always do. You take a bite, go across, take a bite, surgeon's throw, square knot, square knot, square knot, square knot, and then you go on and do this pattern. So you start the same way that you do the other ones, and then you take bites that are parallel to the incision. Parallel, go across, parallel, go across. Notice also where they're entering. You know, when they go across, they're going straight across. They're not going at an angle. They're going straight across. And then parallel, straight across, parallel, straight across, parallel. So it's the same plane, same plane.
It's not squishy enough. Yes, so like. Yeah, you want them to be crossed, you do not.
And hopefully you'll notice the inversion as you go longer and longer with this suture pattern. Hopefully you'll see it invert. It might be a little bit weird with these prosthetics, but in a real animal you'll see it invert.
Yeah. That's.
Is that what it is? Okay.
Yeah.
Because that's what they do, but
Yeah.
probably wouldn't.
But it's trying, yeah. It's trying.
Oh, I see.
Right,
You go,
right, okay, got it.
across like this. Parallel to the incision, and then again here, parallel. You're always, yeah, you're going across each time, so you're gonna go, so it's hard to explain what you need to do. So, parallel,
Instead of doing your bites.
yep.
Because normally.
That's right, at 4 weeks of age.
Oh, yeah.
I see what you're
Go
saying.
across, parallel, yeah.
Okay, I see what you're saying. Yes.
Yep, go right and straight across, so where we exited, will be the same plane where you're going to enter.
And how do you tie it? How do you end it?
Yeah, so you have to create a loop.
Okay, so you
So-
come back across.
Yep, come back across,
You're leaving this on your.
Yep.
And then you can tie
and then you
it.
could tie it. Mhm.
Okay.
Yeah, because these are, usually, again, I only use these for intra-abdominal organs, and it's nice that this not buries, it does not require that it buries. There you go. Yep. Yeah.
That's your second layer.
My pleasure. Good. Oh, wait, yeah, back it back out, or cut it, whatever you want, and then that gets really hard to back out. But yeah, you have to go across, then parallel again. How we doing, folks? The other ones? Sure. Sure, fair enough, fair enough. Yeah, no problem. That's what you're here for, right? To get what you can. How you guys doing? Any help? Yep, that's right. Go parallel. Yeah, when you're gonna end it. Parallel, yep. There you go. And you're trying to end it now? Yeah, so now you have your loop. Yep, surgeon's throat and square out. Yep.
But you can hold on to your tie off here. 18 every year. So like if I get over 18 for my next year, I can use it. Right. It rolls over, you only show it there. You can use it in that, you don't use it in the shelter here. It's only flexible, probably. Well, we're only allowed 9.
I don't like
Whether it's
Oh, I didn't see that.
live
I
or
said it was
not.
true.
911.
Doesn't mean I want to do that, I like to. I had one that they got because I was having vaginal bleeding.
I gotcha.
And there wasn't space, but it also, and it wasn't
Just a seating preference.
Yeah, like it was just flat out not space.
It was just flat out
No,
not
no
space.
remnant, no very remnant, just flat out. Even this, oh, the space is,
I gotcha.
It's like, it's just like a scar scar.
I would still rather just have to do it every
very nervous, it's like over here, it's like $360 tax in Michigan, and they'll look for the veterinarian one. Or you can just put that. There. Actually, you can either way, you have a spec. I've got spare and
I was
yeah,
gonna say,
rent.
yeah,
An hour away, and I've been down there.
Which is not fine for me, but.
CDC was down there for at one point, I don't know, so just hot out there. But I was down there. They were, and now they have the MGM as well.
Yes. Yes. Yep. Yeah. And you see how he's pulling it right? Yeah. Yep. That's right. Yeah, square knot and then, oh sorry, surgeons and then square.
I recently had someone with a spay tattoo from the shelter, which I know is pretty common, but it was a light skin dog. So they put the spay tattoo like under its labia, so it would be like more hidden, so that when the dog did like roll on its back, you wouldn't have this blue line.
Sure.
I've never seen
that before.
It was all the way back by our privates, like.
Interesting.
Yeah, because I guess they were worried that people would like see it, because she was light skinned. Never, I always seen it like right to the side of the initial.
Yeah, me too. I mean, I always question why we don't put it in other obviously they're hairless in the bottom usually, right? But I always question why we didn't try to make it more cosmetic for them. But I've never seen that before.
Yeah, it was to make it more cosmetic.
Yeah.
I was like looking back there.
It's hard to find that.
What is this blue thing? Well, no, it's pretty easy if you just look, but it's not.
Yeah, you don't know. Look.
For this one?
Yes.
What organs do you absolutely want to make sure you're not?
So for me, it's going to be urinary bladder because theoretically there are some studies, that this creates a nidus for crystal adherence and then stone formation. And then for the stomach, although maybe less so, but the gastric acidity, in theory, if it touches the suture, could destroy it. But to be fair, with the stomach, usually your first layer is actually going to be an appositional layer, so typically simple continuous, and then. Right, yeah. So, but those are the two that I would, and then I wouldn't do it I wouldn't use it for intestines at all. I think in large animal, do they use inverting for like enterotomies or I can't remember. Yeah. Though someone told me that, but yeah, you wouldn't use it for.
It's so huge, it's like arm
That's what I'm
size
wondering. Yeah.
intestines,
Yeah, but those are the two.
Do you always do it on the
situations.
stomach, or like do you do an inverting,
Yeah.
and continuous and an inverting?
Yep. Yeah, 2-layer closure for the stomach, always for the uterus, and ideally for the urinary bladder, although if the bladder is really screwed up, sometimes you can't. Sometimes you barely have the one layer that you can work with if it's really like traumatized bladder. Okay, let's see. Folks, want to move on to the next thing?
Yes.
Let's do it. So typically I reserve this part of it to kind of revisit what we've already done. So I'll just go through a quick reminder and then we'll go through more complex knots. So just remember the square knot, yay, mastered it, surgeon's knot, simple interrupted, phenomenal. Feel free to practice those. You got simple continuous, you got forward interlocking. Don't forget the tension relieving suture patterns, so cruciate, horizontal mattress, vertical mattress. Those are awesome, and there they are there, and you guys now know how to do them, and if you want to revisit them, we can, of course. And now the Aberdeen knot. So these are a bit more complex. I don't use these knots, but folks in here are excited to learn about them, and so we're going to go through it. So we're going to play this video several times. It'll go in slow motion in the beginning, and then it'll go normal speed. You can see they started off by doing like a simple continuous pattern. So that's how you'll start this off. You do a simple continuous pattern, but then to end it, this is how you're going to end the continuous pattern. This is the Aberdeen knot. Looks easy.
It's always a hand tie?
Well, so who here uses this knot or has used it? Is it always a hand tie, or do you use instruments for it?
I pretty much hand tie it. I'm not sure how I would do it with instruments very well to keep attention.
Yeah.
School taught it with only your hands. They didn't teach it.
School taught with hands. Yep.
Why would you pick teal yarn? With a teal. Come on now.
I didn't make the video. It was donated to me. Yeah, I know.
It's like make it black or something.
I know.
It's like the suture material, and you're on like a white dog and it has white whiskers and white. It's like you can't tell if it's
Yeah.
a whisker or the suture material gets bloody. It's the same color. It's
Do you find them to be less secure than tying to a loop?
For these?
Yeah.
So see, I think yesterday someone told me it's more secure. Do you feel like it's very secure?
Very secure, I mean, it does take a little bit of practice to hold the tension when you're initially doing it.
Yeah, yeah.
But some studies have shown it's actually more secure than a square knot.
I saw it, like, they taught it in school and it just,
Well, and then-
it felt less secure to me.
Yeah.
So I don't use them to freeze it out.
But the idea is that then that length that you have, now you start doing your subcuticular with that length, correct?
What do you mean?
So this is supposedly your linea, right? So you tie off your linea, and now you're all done, and you have that one free loop, and then now you start, without cutting it and making a new loop, you start doing your subcuticular with that length, right? That's the idea.
Using the same strand of suture? Oh, that I don't know. I don't
That
know.
I think is the idea. So you use fewer knots.
I think you can do that with any.
You can, but yeah.
Yeah, we're looking to do that with a simple continuous,
Right.
simple continuous bag.
With the same,
Yeah.
yeah, right.
I've never
But
done
see
it.
that length, like that length now you would start doing your subcuticular in the opposite direction.
Mm. Yeah, I'm always doing it as a separate thing. I've seen that before, but I've always done first linea, and then subcutaneous, and then subcuticular, and done.
And it's gonna be, your knot's gonna be perfectly buried because it's attached
Right.
to the other,
Right,
yeah,
right,
to
right,
the other
right.
thing.
They taught us smurf it
Oh, okay.
to bury it. So you like do it that way and then you smurf it.
Yeah, smurf it. Yeah, that's right. I smurf it. I smurf it. Yeah, for that.
That's when you just kind of take a bite and you go as far,
Play it
reasonably
again.
far away, and you just pull it until your little knot, like, yeah. And they call it smurf because smurf means everything. Yeah, smurf means everything. How Smurfs! Oh, no! Like, literally, it means everything, right? It means
Yeah.
hide, it means pull, it means.
I've cut my suture line, if I have to do that before with the reverse cutting, I've cut my substitute line underneath and I never redo them.
See, that's.
I just leave the little knot out, it makes owners come back because they see it there, so it makes them come back to get that little knot out, I just leave it, I just leave it there.
You don't worry that the dog or cat's gonna bite it and use that to pull.
So I'll walk around. I'm not sure how much help I can be with this one, but
This one I have no idea how to do, I guess I need a new length, it looks like you need very long. Yes, this one I have no idea how to do.
there you go. Yeah. Yep.
Yeah.
And I guess one of the things they're discussing is maintaining tension as you do each one of those knots, and that's where it becomes difficult because if you don't maintain your tension, it'll seem like it's a pretty loosey goosey
Don't let one bad experience.
closure. But otherwise, yeah,
We call that
it's perfect.
experience bias. You can have weird frequencies happening. Like that cat, that
Keep the
cat
tension
that
going.
pulmonary
And also, I don't know how much of it is material because he's using that might be like rope or something, and then there's more friction with the cloth, whereas these are very smooth, and the fake thing is more resistant, so it may not feel as natural. But yeah, that's great.
I have cut my own
That's great.
suture material. That's right. Totally. Break, I'm doing a continuous that breaks and I just start over.
Looks good. Yeah. Well, that's what they were talking about before. That's the challenging one with this suture, maintaining tension to actually get a snug closure. So, because obviously if you don't, then it's just gonna be loose. But yeah. Subcuticular. That's exactly right. Yeah, that's what they're talking about at the other table too. That's how you use it. Let me play the video and we'll do it together. Then you pull on this side.
It's super weird, and it'll never happen. And I'm not taking a chest X-ray on every single case. You should not put too many options out there.
Yeah, this one was a tough there. This one was a tough one for me too, because I never use it. But
I never use it either.
Yeah.
So biased by your experience.
and then again, repeat, yep, and then pull, yep. There you
This
go.
part I was.
There you go. Yeah.
But then it looks like you should be able to pull.
You're supposed to be maintaining tension the entire time, and that's the part that seems to be the hardest with this one. Because if you don't maintain tension from the beginning, then it's going to become loose. Yeah, that's exactly right.
That's exactly right, but now, I mean, but then it looks like on their thing, they pull this down, and when you do that, you lose it, or do you?
It's both, I thought it.
Take your long end from needle.
Like that.
And then you, she's missing the last step. And you're going. Take your where you're needling and pull it through.
That's the part I don't care.
Yeah, yeah.
How do you finish that?
You pull it through.
Yeah, no, that's why I don't like the even when I'm looking at it.
Pull it through.
It looks like it's going really hard.
Yeah.
The tension part though. I don't
Yeah,
crochet.
this is now how I do my knots when I do crochet. I like it for crochet. I don't like it for suture, but I like it for crochet.
That's usually like the neck crochet the leg.
Yeah.
I like it not having to let.
No idea.
As long as you're stitching it, I'm ready to set it
No,
out.
it's good stuff.
Get you this one where you're like,
Oh, you're ready to try.
How do you end it? We had a question that's here about how to end it. That last thing he does, just when you pull it through, it's gonna like unravel. There's some sort of-
So in that spade clinic that I got kind of value pick, that's what they were around. They also have crazy one
Oh, I see. Okay. Let me see if he's at that point.
This tight.
Are you at the point where you're ending it, or?
you're trying to get it
Well, she's the one person who does do this. You want to sit next to her and have her position on? I'll watch you guys too. 'Cause it's it's not one that I. This one? The Aberdeen? Yeah. When I first saw this video, I was like, what the hell? This is cool. Yeah. I have not used it. I don't know why I would. You know. Right. Yeah. I just know some folks want to learn this one, and so that's why I incorporate it. But I never looked at this one in this lab. No, just simple continuous, or just like or I'll do like a particular pattern for the sub Q to get it more opposed. But I never learned it. Until I had these slides donated to me, I never even knew this existed. And then I'm like, oh, okay. And so I'm learning from the team, like, what do you guys use it for? But I don't know why I would. When I already feel like I'm pretty fast with my current techniques, so there's no point. Yeah. And it's a hand tie. I'm not good at hand ties either. Yeah. That's the biggest challenge that I'm hearing from other tables is maintaining tension while you're doing this one. If you don't maintain tension, it's going to unravel on you. It is back through.
So when I would pull it down, it's like,
Yeah. Thank you for helping,
Come
yeah.
back the other way.
This one's always been on my, I just don't use it. I just don't use it. Yeah. You know?
And then really the question is when do you wanna use it for that first time?
Right.
I'm
Yeah,
sorry, I'm a little
yeah.
superstitious.
Right.
Sort of what you're doing,
Right.
right? You're doing the.
I hear you.
Yeah.
Yeah.
It is.
Yeah, yeah.
Two-handed.
No, I'm sure it's got its benefits to it. It's just, I mean, nice job. Nice. Let me play it again for folks.
That one.
Here.
Those are.
Play the video again, folks want to see it.
So I just came out this side, yep, I loop it through.
Right, practices the wrong way too many times, or?
Look, that's two-handed here. Lower back,
That
yeah.
Take it off, push it down, just, I'm not so nervous. But it seems, everything really matters.
I don't think it matters which one we do first.
Maybe a few more minutes and then we'll move on to the next one, we'll see.
Yeah, that's the only difference, it's the same movement, it's just when you use your right hand, you use both, either one use one. That's fun.
All right, folks, we'll move on to the next one. If you, or some people still practicing this one.
I guess I just don't really see like the advantage of it, I'm probably missing something.
Yes, what I've been hearing from folks who've been doing it is it does have really good tension and it's really fast. There you go, yeah. So my thought is, again, I'm not gonna start using it, but if folks wanna give it a shot in their practice, when they feel confident enough to do it, then have at it and see what you think.
And I'm sure you get fast at it when you know how to do it.
Yeah.
It's like, my son is 8, and it takes him like 2.5 minutes to tie his shoes.
Right.
And I do it in like 4 seconds,
All right.
you know?
Yeah, if there's anything else, if you wanna try a new thing, this is an option. All right, let's go on to the next one then. We're gonna do a modified Miller's knot. And then after this, we'll do the Miller's knot. So, modified Miller's. And again, not one that I use that often, I'm sorry, but I'm sure a lot of folks here use it. How many people use modified Miller's? Yeah, okay, good. Yeah, a good number. So here we go. We can, let's go through it. So this is for pedicle ligation, for ligatures. So you're going through. And of course on your board, on your prosthetic, you don't have any pedicles, so you'll have just pretend like the incision is a pedicle.
I can suture my apple.
That's modified Miller's. We'll play it again.
So it's always a hand tie?
Yeah, when I was in my residency, they were always using this for hand ties, with hand ties. But folks who do this, do you use instruments for it? Instruments? Either one? So,
And they recommend this
preference?
as a sole knot on the uterine pedicle.
Yes, that's right, yeah, right, that's the advantage, right, that's why you folks use it, because it's more secure, you can get away with just one ligature.
Yeah, and you still have to do it in a crush?
Do you do it in a crush?
No?
She does.
Yeah,
Nope,
I have
yes.
no idea, I don't
There you
know
go,
how to do it.
different opinions.
So some said yes and some said no?
Mhm.
Okay.
Welcome to life, yeah.
I know, that's okay. Can we see it again?
Yeah, of course, yeah, I'm gonna replay it. I forget it's a fast video.
Pass it around.
I think when I do my pedicles for like a spay, I don't always crush either. It just depends on the size of the pedicles and all, and how.
If you crush your rabbit spay, it's gonna transect it.
Exactly. If you're doing like a kitten or something, it'll go. So I just don't. But if a large, large breed dog
So
or
it's almost
something.
like a surgeon's knot, that you're doing two like base loops before you start to pull it tight.
Yep. Play again.
Interesting.
Okay. So it's coming around one edge, coming through, then does again parallel to it, coming through,
But the
and then
lo-
to
but
finally
the knots
tighten it.
don't cross each other until the
He
second
loops
loop.
it around
After the second loop.
after the second loop, loops it around, and then ties it. We'll play it again.
Use my watch. And this is my pet. Here's my uterus.
So he comes around first go, comes around second, and then he's gonna go through the two loops.
So the free end.
Through- Yep, the free end goes through the two loops, and then pull down. Around, through the loops, pull down. Play again.
You cross it over. you
Yeah,
can
I don't
pull
do
it.
it that way either, and even that way's confusing to me, apparently, I do some other ones.
So you need like a pretty long amount in your free hand? It seems like.
Yeah,
you need
yeah,
a
if
big
you're,
amount.
it seems like you need to leave a long tag to it.
Right, yeah, like my
To make the X, and to do it with the X in your fingers, which goes around the thing.
That's like the video I watched. This is totally different than the YouTube video that I couldn't figure out. It's like. Do you mind coming over here? I
Yeah.
just don't think I'm doing it. I'm pretending my watch is a uterus, my uterine head.
Oh, nice, sure.
So, alright, so this is my big dog uterus, right?
Mhm.
And I crushed it in the plant, so I take my suture. So pass it around, pretty
That's
big,
one, yep.
pretty big thing, pass it around again.
Yep.
And then, it looks like now only one loop, so I need one more, or is this, cause it looks like I only have one, and I'm supposed to have two.
Yeah, should have two. You replay this. I wonder if you're pulling it too tight, like if you should leave the first loop loose, and then when you do the second loop, leave it
Be more
loose.
obvious.
Yeah, you might be tightening down. Yep, you should have two loops. Oh, there you go, okay, I see it.
So is this, so I did one loop, and here's my second loop.
Let me see. It's so hard to see with the colors. Yeah.
And then it goes through.
And it goes through that way. Yep.
Just like, I don't know. And
Then cinch it down.
then I assume I have to pull it the opposite direction.
Mhm.
Since only one is.
Over first? That's why I'm.
Sure.
Once. So maybe that's not twice, maybe that's only once.
Oh, yeah.
I think I'm calling it once, and it's a half.
And then again.
And then one.
There you go. Yep. And then now. There you go. There it is. And then now you go around. Yep.
Push it through.
Yep. And then pull on both sides.
Like that?
We lost it there. Looks like we lost it there. Let's see. Play it again. So loop. Yeah, I think we're just not holding that other end secure enough while we're doing these loops.
There are just two, is that too many now? What, too many loops now? I went around what I thought was one extra time. And then am I supposed to but like.
We're supposed to go through both of them.
But am I supposed to be holding it, like what's the?
Like, I never use like the transfixing.
I know
Uh-huh.
transfix.
No, I mean, if you have the ability to do that, you don't.
No, it's too many loops.
So there are YouTube videos on this, but
Yeah.
I couldn't follow it, I tried.
It doesn't have the, we don't have pedicles here for this.
This is like a pedicle.
Yeah.
Sometimes I'll think of it in
This
movies.
counts as 2 loops, like if I hold it like this.
Yeah, and then now you can go through, yeah, then this is the part that we're losing the,
I'm losing the second loop.
yeah.
That's why I think maybe, so then when I did one more loop, then it was 2 loops. And you're not supposed to do a loop like a hand tie.
Well, like one of the. Yeah, I
So
saw, I
for
put one
example,
on
if I
like a
was doing a hand tie, I wouldn't feed it around twice. I would pass it under
Mhm.
and grab it with my finger to make the loop.
Yep, yep,
But now I
yep.
only have one.
Yeah, yeah.
That's good though, you it's all in there, in your fingertips, you don't even.
This thick, you went around just once.
That's just once,
Right.
right, so that's not gonna work.
Yeah, you gotta go around twice.
But surely there has to be some hand motion that's less awkward than this, do this.
I tried to show you how to do it.
No, it's not.
Oh, you did, okay, my hands just aren't working, but I get
Right
the
now,
gist.
I'm trying to learn like the feline models.
I feel like it should be able to put it through or something.
Sure.
That's a good idea.
Yeah. You doing it on here?
I'm about 50-50 on getting it to stay.
Oh, okay. I got you.
Oh, I see, okay, okay. Yep.
It seems like,
Go around, then go around again.
like I'm tightening it up this way.
It should be,
Like
it
this.
should be like these kind of loops, like big loops,
Keep it that way.
right? And then with that free edge go in between them, yep. There you go, and then tighten.
I had that once.
Yeah, I wish we had something that actually is like a vessel to see if it would, because it may actually,
Surgery. Of course, this is.
folks who do the modified Millers, do you wrap anything else? Do you supplement to the other closures, or is just the one time, the one knot?
Theory, it's supposed to
Bring 'em
just be
in.
that one knot.
For my space, I do that first, and then I do a surgeon to my
But proximal to this, it's like a separate,
Yeah.
separate
There's
ligature.
two, yeah, I always put two ligatures.
But for this one, you only do the one throw. and
Oh,
then-
no, I'm sorry, 4 throws over that. So
For-
you just over that. So after the 5 throws, 4 or 5 regular.
And like square knots or,
Yeah, so that's like your first, your first throw,
Mhm,
and then you do your 4.
In theory, it's supposed to be secure enough that you only need
One throw?
one knot.
Oh, yeah.
One miller's knot, and that's
Yeah.
it for your release, that's the idea.
Mm.
Yeah, but I get it, if it's like some monstrous thumb size
Sure.
pedicle, putting another one on.
let me play it again.
So if I pass, some of the things is how you're gonna set one, but you don't tie it, you just pass it, you don't
Correct.
touch it.
Pass it through.
And then hold it.
That's why it doesn't stay.
Yeah.
Yep.
So
So now you
now
have.
this has to become my long edge set, so pull this. It's still only this. So this is just one.
So that's exactly what, no, so now you've gone around.
That's what I thought.
So now.
This is my long one. I've got my needle.
I got it. Oh, okay, then that's fine. So you have to do your long end interceptor. So now you're gonna take these, and you're gonna pass.
Right,
it
just
under.
there.
Now, am I
Yeah.
still holding this while I do this, or I let it go?
You might have to let it go, cause there's actually.
Pass it through,
Yep.
and you said grab.
This one over.
With my other hand. Oh my god.
I know, I'm trying to think. train my brain to explain it.
Yeah.
Hold on, oh, look, it's a swan, and I'm just like, what?
Yeah.
So I go my first one around, I go my first one through.
Play it again.
Second one around.
Yes, I say, no,
Should we move on to the next one? Sure.
I got an F on that one.
That's all right, it's all right, it's when we practice. So this is just Miller's knot, okay? You just did the modified Miller's, now this is the Miller's knot. Goes around once. Now he goes around again, but the other side.
On the far side.
The far side, it's not parallel like you did. It is parallel, but it's crossing over.
Yeah, I made an X. Oh, interesting.
Let's play it again.
Three-dimensional thinking.
Yeah. This is the good stuff.
Do you use Miller's knots?
I don't. If it's like a spay, I'm doing transfixation, is what I'm doing, and then usually I'll support it with like a circumferential. But the transfixation suture is towards the patient, just in case. Otherwise, if I'm getting fancy, I have ligature. So just cauterize it and cut it.
Get all the knots.
Be done with it, yeah. So I don't do this. You know, things like ligature didn't exist, right? You know, and so now we have this awesome instruments, and if you're fortunate enough to have it in your practice, it's
Did you say a ligaclip? Is that what you said?
ligature.
Ligature.
Yeah, it's a bipolar sealing device.
Oh,
Bipolar
I like ligatures.
vessels.
They exist.
It's awesome. Well, yeah, there's LDS staples, there's hemoclips. You can use those too for vascular surgery as well. But the original thing are these hand ties, and they're very secure. But yeah, I do transfixation is my go-to for pedicles, like for spays. If it was like a splenectomy or whatever, then I'm doing circumferential if I'm not using the fancy stuff. Otherwise, it's circumferential.
Okay. I feel like that'd be more work for you though, right?
What?
Splenectomy, right?
Yeah, the LDS, the ligature makes the splenectomy 30 seconds long. I can remove the spleen immediately.
Cuts down on your blood loss.
It's ridiculous. It's like cheating on surgery. Like it's amazing. It's amazing.
Love it.
Did you hear about that human surgeon that did it to a liver and killed the guy?
Yikes. With a ligature?
Yeah, with LDS. It was supposed to be.
Oh, LDS.
It was supposed to be splenectomy, and he went in and he did it on the liver. And so he took out an enormous piece of the dude's liver, and the guy died.
Yeah.
And he tried to submit it and say it was spleen, and it was obviously liver.
That's horrible. That's horrible. I'm not even sure how you would do that with an LDS.
Well, maybe it wasn't an LDS specific, but it was a ligate divided staple.
Yeah.
So the purplish organ was
Yeah.
supposed to be the spleen.
With laparoscopic, is that why there was confusion?
Laparoscopic, and then the guy bled out before he
Yeah,
could,
yeah.
because he.
It's not strong enough to, if the liver's too thick, right?
Yeah, and all the veins are
Yeah.
massive, so the dude.
If I do LDS on the liver, usually I crush the liver parenchyma first. I do
And
crush
you're probably
it.
just doing the tip of a lobe, you're not doing.
It depends. It depends. It can get pretty intense depending on what you're trying to remove. It depends. If it's that small of a liver lobe, then I'm just gonna do like the guillotine method or just cautery or something. All right, play the video again. Miller's knot.
And the vascular supply.
So that's this.
For his, okay, you're a nurse.
Okay, alright, I want my
Yeah.
wand Right. This lion over, and then grab
That's where I'm going.
Oh.
I'm slightly terrified to not touch it.
See, I one
three or four on top of it, and
Is
it's
this one?
regular old.
So you're using paper? Oh,
Here's the,
nice.
Yeah,
Yeah.
That modified look would be hard to figure out.
Awesome. Yeah. Good.
Cause I found the,
And you just modified millers, or did you also add on there square knots?
Well, that is fair.
and then you put the hard, like the hard number, and they said, we're going to pull down. And when you're there, like,
Similar drill. Yep.
I think for big animals, like something this big,
Yeah.
type, but I've had Yorkies, I've had Yorkies where I put out my nose
That
Another thing I've discovered that's been tendency to do is not.
They pay really well, they make good like food, things like.
Very cool. Yes. I think that's the modified millers. Yep, because you didn't cross over with that initial loop, you went parallel to it. Yep. The miller's not, instead of going parallel, we went across and then through. See?
I got rid of the video and modified things 20%.
And now somebody's going after it right now. So it's worth it to see what the talks about is with the whole.
And this is millage or this is modified?
I thought it was a modified millage, but it's not the same modified millage.
Yeah,
Are
this-
there multiple, can there be multiple versions of a modified millage?
There may be.
Okay.
I have to look at the textbooks and see what they have there.
Cause now I'm confused.
Yeah. Yep.
I generally like this, this is not the other way, I like how to keep these, so there's my second one. Make this long.
So since we have some time, if we want, we can practice. I skipped this one before because again, our models are not great for this type of closure. But this is a very popular, I use this all the time to close skin and to actually avoid even using skin glue or skin sutures. So this is a subcuticular subdermal pattern. Again, it's going to be challenging on your models, but since we have time, if you folks want to practice this one, it's great. So once you start it, and we'll have to go over that, you'll take bites in this pattern in the subcuticular tissue. So it's not in the skin, it's in the subcuticular tissue, back and forth, and that zipper-like pattern makes it a really nice closure. Starting it, though, might be a bit of a challenge. It's similar to that other video I was showing you for tacking suture. So how I would probably start the subcuticular is go deep to superficial, and then superficial to deep. And tack or not doesn't matter, but that's not the point of this exercise. And then do your surgeon's throw, and then square knots, and then go to subcuticular after that. So this is how you'd start it. Deep to superficial, superficial, deep, and then surgeon's throw, square knot. So if you folks want to practice those, that's how you'd start it, and then I'll leave out the picture of the subcuticular pattern, and I'll help with this one for folks who need it. How many folks already do subcuticular patterns? Yeah, a lot of you. Yep, yeah. Yeah, so feel free if you already have mastered this one, practice anything else you want to practice, because this is pretty much the end of this. So I'll leave the drawing up for subcuticular. Did I miss it? I think I missed it. There we go. Okay, there it is. So that's the pattern that we're looking to achieve here with this. And again, like I said, it'll be tough on these models because you don't really have like a differentiating layer. So you'll have to imagine it, do the best you can. Yeah, okay. You would try it? Trying to think of like a safe-ish case to do it on, you know, where if it does. Yeah. Yeah.
Small incision, for some reason it's failed,
Yeah. And you still have the skin will be hopefully intact anyway, so it'll, yeah, no.
Skin sutures in the first few until it
I'm gonna have this talk on my YouTube channel, so if you want to reference these videos again, I'll have my YouTube channel at the end of the thing, and you can feel free, because I'm sure folks, if you're gonna want to do this, you're gonna want to practice it again, I'm sure.
Well, it's funny, I have like two kids, so my son.
Oh, nice. Oh, in the dark
He's
side.
yeah. It was cute. He actually worked in
Yeah. And he didn't like it, or it was just, it was.
His interest in
Yeah.
a lot of like neural work.
Oh wow. Good.
Interested in. And while the veterinarian, he's having a hard time taking over the higher schools, where they think they have more better he worked for me. It was fantastic. I had a great time.
Yeah. Well, look, I mean, either way, it's a win-win the way I see it. They're both great professions, you know.
Listen, he's really happy. He goes in, he works Saturdays because he wants to. That's what she's
That's so cool. Yeah. He's in his early 20s? Yeah, great. That's cool. That's cool. What's that? Yes. Yeah. Yes. Yeah, if you guys want, you can take home the fleshy rectangle stuff, and then also the suture packs as well. Feel free. Courtesy of PRN. So you can keep practicing, of course. I'm just going to wrap it up here. So again, thank you, Dr. Kirk Miller. He donated all these slides, and I modified them. PRN, thank you very much for sponsoring this. And this is my contact information. I will have these videos up on my YouTube channel, so feel free to check out my YouTube. And then this is for my company, obviously, VetTriage, but all the socials. My email if you want to reach out to me directly. And yeah, it's been an absolute blast. Hopefully you guys learned a lot and can implement these things in your practice. So thank you so much. Thank you. You're welcome. Yeah, you can leave any time, but feel free to practice. And we've got a few more minutes.
Correctional now, and you can't go.
And you want to do that's, we would do more if we were question mark.
I don't know, I do one round, but I don't.
Yep.
Yeah,
That's fine.
Okay,
Okay, so you just make a cross.
I'm trying to get cabbage, so like a surgeon, so
Okay.
the other side.
Okay.
Just like that, sometimes I'm tired, sometimes I'm yeah, right. Right, when they come in, they get weighed, they get help, they get, sometimes like you're being confused and training into the
Sorry about that. Just wrong. Said me some of the things, and I think I was down there. Good.
Some of the folks from the experience and the practice of the work done anyway, and so they were just sharing stuff. And
Thank you. I apologize. I was so upset.
And I was like, I'm gonna modify his talk some more, and if you have back other things, what I was thinking was, is there a way to, have things like, the vascular surgery, because it's tough, it's like,
I know that. I'll definitely try to get some of those. Deeper on about some of these.
I didn't know if also these flesh or rectangles, is there a way that they simply could be, like maybe it can be a small rectangle, or it's a little deeper, and I don't know if that's possible. But this is more important. This is like, there's some way of, people were like suturing their watches, or suturing their pens and paper, you know. So if you want to.
Yeah, no, I think that's a great idea. I'll definitely look into that. And, about the other thing, it's going to make it more, like I said, the other thing with people. You can I'll get to you for, but yeah, you can take it.
That's awesome, thank you.
Question.
I'm trying to get it where it's all the same one. These are the really cheap ones. I want to get really high end ones, so that's why I'm talking to you. I'll try to get some higher end.
Brown hands and
It does, but the other one really inexpensive. And I've talked to the guys who have supplies here. And I've also talked to them. Yeah, I'm learning too. Yeah, it is important. Yeah, because like the squeeze, you don't want anything in there.
Let me see the end.
Little squeeze they have, not the book line.
Yes. If you don't mind, then
No, it's perfect.
You can also email you too.
850.
Yes. Good job. Yes, so veterinarians are always hiring vets, technicians, it comes and goes. I have, again, are you a vet or a technician? So they have about 6 or 7 clinicians, and they do admittedly provide more of a customer service role, less so medical. So it kind of, your skills in the clinic, this is a piece of cake for you. If you want to figure out what your job and all that stuff. The only thing is I'm thinking I'm gonna need to hire more probably like springtime next year, unless someone drops out, you know? But the ones I've had for a few years now, and they're hanging out. So if you want to, email me, your name that we met here, and also your resume, and we can always reach out sometime next year or sooner if time changes. Yeah, no problem. Nice to meet you as well.
Have a good day.
I typed it in, I don't know how to type it in.
Sure.
Just check. PRN.
You're very welcome. Thanks for attending.
Thank you.
Good job.
What if you like, you can see, she's like, oh, you don't wanna know.
You're 845?
845, yep.
Yeah,
There you go.
snake swimming and like blood and like.
Cool. I'll take you a picture of what I'm thinking.
That'd be perfect. I got your numbers, okay, cool.
Cool, man.
And I'll help clean
But I
up
was a little.
anything.
They probably really
And I
want,
feel like
they
they do really
probably
well.
did it.
My
Because they
coworker
wanted
is
you to
not
get
like,
out.
it's not
In the house,
I don't wanna get something like forward and protocol. Or like my coworker at the shelter, like, okay, that's fine, I can do that, but I can't stay.
Otherwise, I would just find
Sunday, maybe I don't know if anything's better than 78 and 78.
Thank you so much for all of your time.
Yeah, thank you too for your stuff, it's always fun to like, trade.
That's why